Yeah, I think can we start now?
Yes, yes. Thank you. Well, welcome everyone. We're very, very glad to have you today in our IAPD 20 virtual. My name is Manal Halabi, and I'm speaking to you from Dubai. And it's my honor today to present our colleague, Dr. Nikhil Srivastava. Dr. Nikhil is an alumnus of King George's Medical College, India, and he's currently the head of Pediatric and Preventive Dentistry and Dean of Subharti Dental College and Hospital in Subharti University, Meerut, India. He is also a member of the Dental Council of India. Uh, Dr. Nikhil has more than 90 research publications to his credit, with a very high citation index, and has contributed to a number of chapters in various reference books of pediatric dentistry. He is a visiting scholar with Indianapolis University in the USA, and he has also served as a guest faculty and examiner the SSR Medical College in Mauritius. Um, he has been a team leader representing India in a group study exchange program to the USA, and has been a part of an international medical team that conducted treatment camps in different countries in the world. Dr. Nikhil is a fellow of the Royal College of Physicians and Surgeons of Glasgow and an International College of Dentists fellow also. He is currently a board member of the scientific committee of the International Association of Pediatric Dentistry, and he is the editor-in-chief of the Journal of Clinical Dentistry. He's also currently the general secretary of the Indian Society of Periodontics and Preventive Dentistry. I am honored to present Dr. Nikhil, and his lecture's title is The Management of Dental Injuries to the Periodontal and Supporting Structures Following Trauma, an Evidence-Based Approach. I will give the floor to Dr. Nikhil, but before that, please allow me to just mention a couple of housekeeping points. And the first point is regarding the participants are unable, they're unable to unmute, so everyone is muted. You can't show your video. Q&A during the live session will be available through the Q&A box. So if you would like to ask any questions, just write it in the Q&A box. And please, if your question has already been written, just like the question, add a like, and that will actually help us at the end, because maybe we can choose those questions that are most likable just to answer live. And of course, after we finish the live session, the participants are welcome to ask questions. If we can't answer them live, you are also welcome to ask questions that are not answered in this Q&A part in the agenda part of the software, the WOVA. Please join me in welcoming Dr. Nikhil. Nikhil, the floor is yours.
Yeah. Thank you so very much, Dr. Halabi and Dr. Manal, in fact, for those very, very kind words about me. Thank you, IAPD virtual platform, for giving me the opportunity to share some of my knowledge and views among all the participants. So good morning, good afternoon, good evening to all the attendees from across the globe. Here in India, it is afternoon, so good afternoon to all my Indian friends. Dr. Halabi has already introduced me, and the topic of my presentation is quite vast. It was very difficult to cover up everything in just a 60-minute or 50 minutes lecture, but I have tried to compile each and every aspect of these traumatic injuries arising as a result of trauma to the supporting structure. These are some of my learning objectives. At the end of the presentation, the attendees would be able to know about the prevalence and etiology of traumatic dental injuries, the injury-specific outcomes of all the different types of luxation injuries, and the principle involved in the management of these injuries. I just want to disclose that the content of these presentations are prepared purely for the academic purposes, and neither me nor any of my relative has any conflict of interest with regard to the content of this presentation. Before I start, actually, I just want to acknowledge this great institution. Dr. Halabi has already told, the King George's Medical College, where I spent more than 8 years of my life. And those who are not from India should know that this great institution is situated in the northern part of India, and this is a very, very big country. And this institution is situated in northern India. And this is the place where I currently work. It's another great university which has 18 institutions in it, starting from dental, medical, naturopathy, law, and engineering, and whatnot. So this is situated in National Capital Region of New Delhi, which is the capital of India. So I shall be presenting my lecture in four major parts in order to cover almost all the aspects of traumatic dental injuries arising as a result of injuries to the periodontium or the supporting structures. Friends, trauma as defined a reasonably severe non-physiological lesion of any part of the body. However, the traumatic dental injuries are any thermal, chemical, or mechanical injuries affecting the dentition and causing an irreversible damage to a number of highly specialized cells of the pulp and supporting periodontium. So I have come across a very, very nice article published in Journal of American Medical Association, which have just studied that what are the different body regions involved in various types of injuries. And to our surprise, after extremities, the face, head, and neck region is the second most common body region involved in traumatic injuries. And if you see the total area of the oral cavity, which is only 1%, but it receives injury as much as 5 times the total area, that is 5% of the total body area. If you talk about the prevalence of traumatic dental injuries, I have quoted 2 articles here, one which was published in Australian Dental Journal and another in India. The boys, as a nature, they sustain more traumatic injuries. Fall remains the most common cause for traumatic dental injuries, and single tooth injury is most common, and that too a maxillary central incisor. If we talk about the place of injury, the home remains the most common place for sustaining these kind of injuries, and school, streets, and other places are they come secondary, tertiary places. We have just heard Dr. Park talking about the increased overjet and orthodontic management of such children. And this, if we can relate the orthodontic problem with traumatic dental injuries, so there was a systematic review conducted by George P. and who said that increased overjet increases the risk of receiving traumatic dental injuries as much as 200%. The other are some child abuses, mental distress, and overweight are other causes which can contribute to traumatic dental injuries. So there are 3 major factors which determine the severity of injury: the energy, the resilience of the object, and of course the shape of the object which impacts or which hits the tooth. So if we talk about the force, a small object, even the small object, but when it hits onto the tooth, it causes injury to the hard tissue structures, while a big mass, when it hits onto the tooth with a relatively low velocity, it causes more injury to the supporting structures. As a result, the tooth is loosened out instead of getting it fractured. Similarly, if we talk about the resilience, a low mass object which is softer in nature, when it hits onto the tooth, it causes more injury to the periodontium and the alveolar ridge or alveolar process. And then a shape is also very important. If a sharp object hits onto the tooth, it causes injury to the hard tooth structure and causes fracture of the tooth, while a blunt object, when it hits, it causes more of a luxation type of injuries because of the injuries to the periodontium. So in short, if a blunt and resilient object hits with relatively low speed onto the tooth, it causes more injury to the soft tissue structure which surrounds the tooth, results in the loosening or the luxation of the luxation injuries. And of course, when this injury is little higher in a frequency, then it results in the avulsion or the coming out of the tooth from its socket. Now, depending upon the severity of the injuries, these kind of luxation injuries can be categorized from very mild and moderate to severe. And I shall be discussing in brief about each type of injuries. Another systematic review was conducted about the prevalence of these kind of luxation injuries, and they found the concussion remains the most common and most prevalent injury as far as luxation injuries are concerned, and intrusion is the least common amongst all type of luxation injuries. So after having a brief idea about these general information about the luxation injuries, let's talk about some of the outcomes. Now, these are the sequelae following traumatic injuries, and IADT is the first time came out with a core outcome set which was developed in dentistry for any of the diseases. It is for the first time in dentistry that IADT came out with core outcome set. These are the group of injuries which can occur, group of outcomes or group of sequelae which can occur following traumatic dental injuries, and these are broadly categorized into two. The generic means the general type of outcomes or sequelae which can occur in most type of dental traumatic injuries. However, there are specific injuries which can occur in a specific type of dental injuries. For example, an intrusive luxation can result in the infraocclusion. And all these outcomes can be favorable where the tooth can be retained in the arch, functioning well, and this can be unfavorably where more intervention is required. And we shall be discussing in later slides. So I'm going to discuss few of the very important outcomes which can result after the trauma the tooth sustains. The first one is the revascularization or healing through revascularization, which is mostly seen when the tooth is underdeveloped. And the repair potential, or there are two major factors which determine the extent of revascularization, one being the stage of root development. And the studies have suggested the larger the apical diameter, more will be the chances of revascularization. Similarly, the severity of injury also determines the revascularization, and the studies have also confirmed that the lesser the severity of injury, more will be the chances of revascularization. The second outcome is very important, is the necrosis, which results from unsuccessful revascularization. The necrosis actually is manifested as a discolored crown, which is brown, black, or bluish in color. The tooth will not respond to the normal pulp testing, and most of the time it is tended to the percussion. If we take a radiograph, you'll find the apical radiolucency and widened periodontal space. And normally the necrosis after sustaining trauma takes almost 1 to 2 years to develop. Now then the question arises, what type of luxation injuries can result in pulpal necrosis? So a landmark study was conducted by Boram, and who concluded that almost all types of luxation injuries can result in pulp necrosis. But yes, the most severe form of luxation injuries is the intrusive luxation, where almost 94% cases it has been seen that the pulp goes on necrosis. Pulp canal obliteration is another important outcome which is seen again in immature or underdeveloped permanent teeth, and it is because of the severe mobility, and the tooth displacement has taken too much because of the trauma. And these kind of pulp canal obliterations are seen in lateral luxations, extrusion. These are two important luxation injuries where the pulp canal obliteration is seen. The crown, again, it is discolored, mostly a yellow discolored crown, and which is seen within 1 year of trauma. The characteristic feature is that the pulp chamber becomes obliterated first, followed by root canal, which is not the case in cases where the pulp gets necrosed because of some caries or some other problem. There the canals first obliterated and the pulp chamber becomes the next one. But here in cases, chamber becomes obliterated first. Now, studies have also confirmed that when we try to reposition the tooth through orthodontic brackets, in such cases, the pulp canal obliteration is common. Another systematic review was conducted just to see the prognosis and complications of immature permanent teeth following lateral luxations, and the conclusion was the pulp canal obliteration was the most frequent complication. And the authors also emphasized the need for a proper follow-up and regular follow-up following lateral luxation injuries. The transient apical breakage is another very interesting outcome following trauma. Sometimes we call it as a miracle because soon after trauma, the tooth becomes discolored as if the tooth has gone necrosed and tooth is non-vital. But within 2 to 4 weeks, this discoloration goes off and the tooth becomes normal. Now, this is just because of the osteoclastic activity in the periapical area just immediately after the trauma, and which provides a natural mechanism and provides space for the ingrowth of new tissue. So color change is very transient and it goes off within 1 month and the tooth becomes normal. The pulp bone is another sequelae or outcome following trauma, and it is again seen in most of the time in immature teeth, and where we try to forcibly reposition the tooth which has displaced because of the trauma. Now here in pulp bone, there is an invasion of bone and periodontal tissues from the apical area into the root canal. But the characteristic feature of pulp bone is that the obliteration or the radio opacity is demarcated by a thin periodontal ligament or thin periodontal line with the dentine. So that is a characteristic feature which is not seen in the canal calcification, where you don't find this kind of thin line separating this pulp bone with that of the dentine radio opacity. Another very important outcome is the resorption. Now, we all have to understand there can be 3 types of resorption, starting from the surface resorption to the infection related, that is inflammatory resorption, and replacement resorption, that is the ankylosis. Now, the surface resorption starts from outside and it moves towards the pulp, and most of the time the periodontium and the associated cementum is involved. This kind of injury is usually seen in lateral luxation and intrusion, and here you find there's a saucer-shaped defect which appears within 4 weeks of the injury, but it is self-lifting. It's not going to progress further. However, in infection-related resorption, which is the inflammatory resorption, which is seen mostly in intrusive luxation, and it is a cup-shaped defect, and the corresponding bone also shows some kind of resorption. Now, how this kind of inflammatory resorption starts from the root canal and goes in the periradicular area, and it is highly progressive. And that is why it is important whenever we see the inflammatory resorption or infection-related resorption, the endodontic therapy should be instituted immediately to avoid the root fracture. The replacement resorption or ankylosis is a generalized injury to all the periodontal structures, and it is mostly seen in intrusive type of intrusive type of injury, luxation injury. And here there is a complete loss of periodontium or periodontal radiolucency, and the whole periodontal structures are replaced by the bone. Now this can be seen as early as 2 months after the injury. A systematic review was conducted just to see the incidence of root resorption after different type of luxation injuries, and they concluded that the root resorption most commonly occurs in association with intrusive injuries, and that too by the inflammatory root resorption. So that is what I told this, that soon after the injury, it is imperative to institute or initiate the endodontic therapy in order to prevent the further damage and the root fractures. The loss of marginal bone is another important outcome which is usually seen when there is a severe compression like intrusive luxation. Now this is manifested as a granulation tissue which is seen around the marginal gingiva, and radiographically you will not be able to see the lamina dura or the periodontal space, and it is mostly seen when there is a surgical repositioning of the luxated injuries. So after having a little bit idea about these important outcomes now, let's talk about the general principles which are involved in the management. So it can be summarized in a very beautiful word, which is an acronym, ROSE. A rose is a beautiful flower, but here it can be used just to remember how to go about the managing the luxation injuries. So where the R stands for reassurance and the repositioning of the luxated tooth. O is the observation or observe or the follow-up, the outcome. S stands for stabilizing the tooth with the help of splinting, and E stands for endodontic therapy. Now, reassurance is one clinical skill which is not very well understood, neither it has been given much importance. However, reassurance is a removal or removing the anxiety, pain, and fear amongst the patient as well as their attendants. And reassurance has several advantages. To name a few, the reassurance makes the patient as well as their attendant feel better, which ultimately lowers the anxiety, thereby lowers the blood pressure and pulse rate, and thereby reducing the bleeding and pain and helps in the healing. Now, repositioning a luxated tooth which has changed its position is also extremely important. Never ever apply too much of pressure or try to reposition a tooth as early as possible. Do not apply pressure, because then we have just heard about the outcome we have just read. The pulp bone is one of the sequelae when you try to reposition the tooth with hard force. And if because of any reason, particularly in cases of avulsion, if the tooth has been wrongly placed in the socket or a wrong tooth has been placed in another socket, then we can always reposition the tooth in a right position within 48 hours. So these things we have to just keep in mind while managing the luxation injuries. The outcomes, we have discussed a few important outcomes, but then these outcomes can be categorized into favorable and unfavorable outcomes. The favorable outcomes means the tooth is asymptomatic without any abnormal mobility. It responds normally to pulp tests, and there is no sensitivity or no tenderness. Radiographically also, the tooth should appear normal without any abnormal radiolucency, any signs of root resorption, or any breach in the continuity of lamina dura. However, the unfavorable sequelae are all pain, swelling, tenderness, increased mobility or no mobility, which are the sign of ankylosis. And similarly, while taking the radiograph, if you find extraordinary radiolucency either in the periapical area or in the surrounding area, periradicular area, all these are considered as unfavorable sequelae to the management of luxation injuries. The third important fact is the stabilization of the mobile tooth or the luxated tooth. The appliance which is used for stabilizing the tooth or luxated tooth or the injured tooth is known as splint, and a splint is nothing but a device used to support, protect, or immobilize a traumatized tooth to avoid further damage to the pulp and periodontal structures. Now, it serves a lot of advantages. Not only it stabilizes, but it provides patient comfort and improves the function, which is extremely important as far as the healing is concerned. A number of splints have been tried, starting from a very simple composite and wire splint to titanium trauma splints. But then the question arises, which type of splints are to be used in cases of luxation injuries and for how long? So, the study conducted by Keller et al. And published in Australian Dental Journal, they said that flexible splints are the best splints to be used for stabilizing a luxated tooth. And why? Because the periodontal and pulp healing are best promoted if the tooth is subjected to slight, that is physiological mobility, and given some function. So after splinting, it should not be kept out of the function. There's some amount of function which are to be performed by the tooth in order to promote the healing of the pulp and periodontal structures. Then the question arises, for how long we should give these kind of splints. So Manal et al., they conducted a study on the animal model just to see the effect of splinting on the mechanical and histological properties of periodontal ligament. And they just concluded that the mechanical properties of more than 60% of the injured periodontal tissues returned back to the normal within 2 weeks. So that is why minimum 2 weeks of splinting are required to stabilize the tooth in position. Then the endodontic therapy. I mean, there is not much difference how to perform the endodontic intervention in these kind of traumatized tooth. But yes, there are 2 or 3 important factors which we have to consider. Number one, the negative pulp testing should not be taken as a sole criteria to perform endodontic therapy. We have to wait for the clinical signs of necrosis or root resorption before we institute or initiate the endodontic therapy. Second important factor is the intracanal medicament. The calcium hydroxide remains the material of choice as far as intracanal medicament is used, because we all know that calcium hydroxide, when it is placed into the canal, it dissociates into calcium and hydroxyl ion, and these hydroxyl ions through the internal tubules travel into periradicular area, and they just change the pH of that periradicular area to become more conducive for osteoblastic or dentinoblastic activity rather than clastic activities. However, if there is a delay in the management of injuries, then it is advisable to first place some corticosteroids and local antibiotics, and then give intracanal medicament as calcium hydroxide. Patient instructions for all type of injuries are again very important, that the patients are advised to avoid contact sports, to avoid re-injury in the same area. The patient should be put on soft diet. As I told, that the function is extremely important. Tooth should not be placed out of function. Some amount of function has to be given to the tooth which is injured, because it will help in the periodontal and pulpal healing. Then the cleaning that area is also very important, because any gingival inflammation may result in the failure of that treatment. And chlorhexidine mouthwash are recommended twice a day, at least for 2 weeks, at least till the time the splints are removed. Then we will now talk about the specific injuries and their treatment. The concussion is the mildest form of luxation injury, which results because of the because of the trauma. There is a mild stretching or crushing of the periodontal ligament, and as a result, the tooth remains in place. So if during inspection, if you try to see, you will not find any significant finding. But yes, when you try to touch, it is extremely tender. The tooth is extremely tender, but there is no displacement, no mobility, and even if you perform the vitality test, it will respond positively. Now, one periapical radiograph with a paralleling technique is recommended, just to rule out the chances of root fractures in such cases. If we talk about the management of concussion, the reassurance, we have already discussed the importance of reassurance. So that is very important. Reassure the patient, and then the tooth should be kept, tooth should be made out of occlusion. And best way to make the tooth out of occlusion is by selective grinding of the antagonist tooth, not that, but that tooth. So selective grinding of the antagonist tooth, this makes this injured tooth out of occlusion. Patient should be put on soft diet. Anti-inflammatory drugs should be prescribed SOS, and the tooth should be monitored up till 1 year. Most of the time, the concussion injuries respond very favorably, so it becomes asymptomatic and responds very positive to the pulp testing. Now, if concussion injuries occur in primary teeth, there are no treatment which is prescribed. The evidences say that wait and watch is the best policy. If the patient is having a lot of pain, then the paracetamol syrup can be prescribed just to relieve the patient from the pain. But more important is to keep the gingival health healthy. And because the small children, they cannot use mouthwashes, so best way is to dip a small cotton pellet with the mouthwash and just try to clean that area at least twice a day, at least for a week, and it becomes normal. The subluxation is little milder form, but little greater impact. Because of the impact, the subluxation, there is a portion of periodontal ligament which gets ruptured, but the tooth remains in the socket. It has not moved out, but the mobility is increased. There is no displacement, but the mobility is increased. However, the tooth is tender. And because the portion of periodontal ligament has got ruptured, so we may find some amount of bleeding from the gingival crevice. And at this moment of time, if you try to do pulp testing, it will give you a negative response. The one IOPA radiograph with the paralleling technique is recommended, though it does not give you any positive result, but yes, we can rule out chances of root fractures in such cases. Managing the subluxation is almost similar to what we have done with the concussion. The only thing, because the mobility has increased, and if the tooth is excessively mobile, a wire and composite splints are given for 2 weeks, and patient should be observed or followed up at least till 1 year. A patient should be given soft diet, anti-inflammatory SOS, and follow-up should be done at 3, 6, and 12 months interval. Now, most of these injuries, they respond very favorably to the treatment, and the tooth becomes asymptomatic with a vital pulp in 90% of cases. Now, if the primary tooth is involved in subluxation type of injuries, again, there is no treatment which is involved, same as we have done for concussion. The only thing, the gingival health maintenance is very important, and if the child is unable to use mouthwash, then the mouthwash should be used for cleaning that area with the help of a damp cotton pellet at least twice a day for 1 week. Wilson evaluated the cases of concussion and subluxation. These are the very mild type of injuries in the permanent dentition, and they said that though these are milder form of injuries, but there are still chances of pulpal necrosis, and that is why a regular follow-up is extremely important in order to provide good results. The next severe form of injury is the extrusive luxation, where there is a complete rupture of periodontal ligament from the labial side and from the proximal side, but from the palatal side, the periodontal ligaments are intact. As a result, there is an injury which results in the tooth which comes out of its socket a little bit, and it appears as elongated tooth. The mobility is increased, and pulp testing gives you a negative result. And sometimes, because the tooth has slightly come out of the socket, that it interferes with the normal occlusion. So in such cases, there are 4 radiographs which are recommended: 1 periapical radiograph with a paralleling technique, 2 one with a horizontal angulation, another with a vertical angulation, and 1 occlusal view maxilla in cases the maxillary tooth is involved. And the radiograph gives you a very typical finding: the increased periodontal space in the apical area as well as in the cervical third of the lateral side of the tooth. Now, if we talk about the management of these injuries, there is a little difference. That reassurance, of course, it has to be done, and the tooth should be replaced in its own position under local anesthetic. But instead of pushing the tooth hard, we have to use slight back and forth motion to just dislodge the clot which is formed at the periapical area, and then push the tooth into the socket, into its position, and then the splinting should be done. Now, in cases dentoalveolar fracture has occurred, and very easy to just locate during the movement or during the repositioning of the tooth, if we find the attached gingiva of that tooth and adjacent tooth is also moving along with the tooth, then we will immediately come to know that yes, there is a dentoalveolar fracture which has occurred. So in such cases, instead of giving only 2 weeks of splinting, 4 to 6 weeks of splinting is recommended. Then the patient should again be put on soft dye, and anti-inflammatory drugs are prescribed just to relieve patient from pain, and such teeth are followed up at least for 1 year. Now, most of the cases, 3 out of 4 teeth which have sustained this kind of injury respond very favorably to this kind of management. If such injuries occur in primary dentition, we have to just see how much dislocation or the tooth has come out of its socket, amount of mobility, and amount of root which is present because it is in the resorptive phase. And after seeing all these things, then we have to take the decision. Now, if it is not interfering with the occlusion, even if it is slightly mobile, we have to just wait and watch. But if the mobility is too much, or if it has come out more than 50% of its cervicoincisal length, then it is better to extract this tooth, because the chances of aspirations are always there when the child is asleep. Lateral luxation, though the lateral luxation, we in dentistry, lateral means mesial and distal direction, but here when we talk about lateral luxation, the injury occurs in the labiolingual direction, and there is a rupture as well as compression of periodontal ligament. One side there is a rupture, the other side there is a compression, and there is a severance of vascular supply to the tooth. And the tooth moves either in the crown of the tooth moves either in the palatal direction or in the labial direction, depending upon which type of injury has occurred. And almost all the time, this kind of injury is associated with a dentoalveolar fracture. Now, most of the time when the impact is horizontal, as a result, the crown has moved in the palatal direction, the root of this particular tooth comes out towards the labial side after fracturing the cortical plate, and it locks into the bone. So as a result, there is no mobility which is seen, and when you try to focus, you find there's a more of a metallic sound as if the tooth has gone ankylosed. In such cases, if you perform pulp vitality test, the tooth will not respond in a positive way. Now, just to best see, we have to use at least 2 radiographs with the horizontal shift, just to find out what type of injury is going to, the tooth has sustained. And the typical finding you will find at some places, you find periodontal space has widened. On the other side, you will find the periodontal space has almost gone off. It looks as if the tooth has ankylosed on one point, and on the other side, the periodontal space has widened. The treatment of lateral luxation is almost similar what we have discussed, but the only thing, because the tooth has locked, the root of the tip of the root has locked in the labial cortical plate. So best way is to put the thumb on the attached gingiva of the tooth which is injured. Just put slight pressure, and with the help of index finger, try to move the crown in its position. So in this way, we disengage the locked tooth position, and we try to replace the tooth in its original position. And because this kind of injuries are almost seen where the dentoalveolar fracture has also occurred, so here, instead of giving 2 weeks of splint, at least 4 weeks of splinting is advised. And patient again should be put on the same thing, soft diet, anti-inflammatory medications, and the tooth should be followed up for at least 5 years. Now, regular follow-up for 12 months, and thereafter yearly up till 5 years, just to see any unfavorable outcome. Most of the time, because this kind of injury is considered as a moderate to severe type of injury, so most of the time the tooth becomes non-vital after this management. So that is why a regular follow-up is done, and at the moment we see at a particular point, when we see the tooth has gone necrosed or the pulp is necrosed and tooth is changing its color, then the root canal therapy should be instituted. However, if it is a young permanent tooth, we have to still wait for the pulp revascularization to occur, and if it fails, then the endodontic intervention is advised in cases of immature tooth. Now, if it has occurred, this lateral luxation has occurred in the primary tooth, where the impact is horizontal in nature and the crowns have gone towards the palatal side, and most of the time the patient presents as if the incisors are in the cross-bite position. So again, we have to take a decision by seeing the clinical situation. In most of the time, if it is not interfering with the occlusion, we have to just wait and watch. But if there is interference with the occlusion, then we have 2 options left: either to extract the tooth, or we can gently reposition it, and we can give a flexible splint provided the child cooperates with the treatment. The intrusive luxation or intrusion are considered as the most severe form of luxation injuries. where there is a complete crushing of periodontal ligament as well as vascular supply to the tooth. Because of the impact which is parallel to the long axis of the tooth goes deep into the socket by breaking the cortical plate, and it appears very shortened. The periodontal structures are all lost, and there is no mobility if you just try to see, because the tooth has packed into the socket. So it will give you a sound of an ankylosed tooth. And most of the time, if you carry out a pulp listing, it will give you negative response. Radiographs, you can see there is a complete loss of periodontium, and the CEJ, if you compare with the adjacent tooth, you will find the CEJ has moved more apically. Now, if we have to take the decision now how to manage this. So management is different and dependent upon how much tooth has gone deep into the socket. So if the intrusion has taken less than 3 millimeters, the tooth has gone into the socket less than 3 millimeters, that is 1/3 of the cervicoincisal of the tooth, then we should allow this tooth to move in its own position, and we have to wait and watch at least till 8 weeks. And if within 8 weeks there is no change, then we can go for orthodontic repositioning, preferably, or surgical repositioning if the patient is not ready for coming again and again. And then splints are given at least for 4 weeks. On the other hand, if the tooth has moved more than 3 to 7 millimeters, that is more than half of the cervicoincisal length, then we have no option but to go for orthodontic splinting and allow the eruption, a slow eruption of the tooth, and flexible splints are given at least for 4 weeks. And similarly, if the tooth has gone more than 2/3 of its cervicoincisal length, then we are not supposed to wait for repositioning or orthodontic repositioning. Rather, it has to be done surgically. So reposition the tooth surgically and put a splint at least for 4 weeks. And rest everything is the same. The only thing that, as I told you, that it is the most severe form of luxation injury. So tooth has to be followed up at least till 5 years. Initially for 1 year at 3 months interval, and thereafter at yearly follow-up, just to see the any evidence of unfavorable sequelae like resorption or necrosis. Now, because in most of the time, in 97% of cases which we have just discussed, the pulp becomes necrose. So it is advisable to initiate the root canal therapy within 2 weeks. Means even if the splints are not removed, splint is not removed, but we have to start root canal therapy within 2 weeks. And root canal, the intracanal medicaments are given. The preferred choice is calcium hydroxide if the management has been initiated immediately after the injury. But if there is a gap between the injury and the management, then it is advisable to put corticosteroid and local antibiotics first for a month, and then it should be replaced by calcium hydroxide as intracanal medicament. Another systemic review was conducted on the treatment of intrusive luxation in permanent teeth, and they found that the evidences are not adequate to find out the best treatment choice, whether it should be that re-eruption, spontaneous re-eruption should be advised, or orthodontic repositioning or surgical repositioning. So at present, whatever guidelines have been given by IADT in 2020, we have to follow that. If the tooth has gone less than 3 millimeters into the socket, we have to wait for repositioning. If it has gone 3 to 7 millimeters, then orthodontic repositioning. And if it is more than 7 millimeters, we have to go for surgical repositioning of the intruded tooth. Now, if the injury has occurred in the young permanent tooth, so it is better to wait at least for 4 weeks for repositioning. And if the tooth has not repositioned itself, then we have to go for orthodontic repositioning. In all the young permanent teeth, the surgical repositionings are not advisable. Another systematic review, another study was conducted just to see the intrusive luxation in the permanent incisors in young permanent teeth, and they concluded that the best policy is to wait and watch. And if at all we have to start endodontic therapy and tooth has not come out in its position, then through the gingivectomy we can expose the area that is the lingual palatal area from where the access has to be open, then the gingivectomy is to be performed. When the intrusive type of injury occurs in primary teeth, then we have no option but to allow the spontaneous repositioning. The only bottom line fact is that if it is affecting the permanent tooth bud, then it has to be extracted. Otherwise, the spontaneous eruption is the treatment of choice for all intrusive luxation injuries occurring in primary dentition. Now we will talk about the avulsion. Avulsion is nothing but a clinical situation in which the tooth is completely displaced out of socket and it has come out from the socket because of the injury. When the injury occurs, we can see there's a gingival laceration, there's a socket expansion, and the socket is all blood filled. The prognosis is dependent upon how quickly we take action at the site of injury, and the prognosis is directly dependent on this. And this can be done. A prompt action at the site of injury can be taken when we have enough public awareness about these kind of injuries. And how to make public aware? There are three ways through which public can be aware. One is the trauma phone call. The moment a dentist receives a call from someone that the child has sustained an injury and the tooth has come out of its socket and it's lying on the floor. So first thing what we have to ask for the age of the patient so that we can judge whether the tooth is fully mature or it is an immature tooth. And second thing, whosoever is the attendant there, we have to advise certain instructions. And these can be summarized as R4. First, reassure the patient. Then rinse the tooth which has come out in whatever liquid, water, whatever is present by holding the tooth from the crown, and they try to return or replace the tooth into its socket. If the people are knowledgeable, they are aware, they can place right tooth into the right socket and right position. But even if they are not aware, just advise them, put the tooth into the socket if the patient is conscious and if he can, the patient can sustain it. And then with the help of any cotton, hanky or whatever it is, that the patient should be asked to bite so that the tooth remains in place and patient should be immediately referred to the dentist. Second way is through the poster which has been released by IAPD, Save Your Tooth. Now these kind of posters should be distributed in all sports ground, in all schools, so that the teachers and the students are all aware what is to be done in cases of these kind of tooth injuries or emergencies. Now this Save a Tooth poster is available in 38 languages, including 5 Indian languages. The third one is a free mobile app which can be downloaded through Google Play Store, which is Tooth SOS. Now this is also a very, very important and significant app which gives you a very important information that what is to be done in cases of any emergency where the tooth has sustained kind of injury. Then coming to the avulsion, management or treatment of avulsion, there are two important factors which determine its prognosis. One, the stage of development of the root, and second is the condition of the periodontal cells of the tooth which has come out of its socket. We all know that the periodontal cells cannot survive out of its socket. So the more the extra alveolar time, less are the chances that these periodontal cells are going to be alive or viable. So based on this, the avulsed tooth is classified into 3. The group 1, where the periodontal cells are most likely viable, means the tooth has been replaced within the socket into its own socket within 15 minutes after injury. The second group, where the periodontal cells are questionable because the time has elapsed from the injury to the replacing the tooth into its socket, but it is less than 1 hour or 60 minutes. The third, which is the worst form, where the tooth could not be replaced into its socket and the time has elapsed more than 60 minutes. Here we presume that the periodontal cells are no more viable and the chances of failure of the treatment are always there. So in cases where the tooth could not be or tooth cannot be replaced back into its socket, So it is advisable to have some kind of a storage media where the tooth can be put in that and can be kept moist, because the studies have suggested that moist tooth still have some chances that periodontal cells will be viable. So these storage media are nothing but the physiological solutions that closely replicate the oral environment to help preserving the viability of the periodontal cells following injuries like avulsion. So which type of storage media is the best? To find out this, a systematic review was conducted by Samira et al. And they just found that the milk is the most viable, best storage media as far as natural sources are concerned. However, the Hank's balanced salt solution is the next most viable storage media for keeping the avulsed tooth as far as the viability of periodontal cells are concerned. Then the treatment guidelines. Now these treatment guidelines though categorize depending upon the viability of the periodontal cells. Situation 1, that is group 1, situation 2, group 2, and situation 3, group 3. But more or less the treatment remains the same, except a few changes, few differences which we shall be discussing. The situation 1, where the tooth has been replaced back into its own socket within 15 minutes. So when the patient is brought to the clinic, do not try to remove the tooth and again try to clean the root surface. No, but the area should be cleaned with the help of saline or chlorhexidine, and then the should be checked for whether the right tooth has been placed into right socket with the right direction, and then it should be splinted with 016 wire and composite at least for 2 weeks. If there is too much of gingival laceration, then it has to be sutured, and patient should be given antibiotics and anti-inflammatory. Tetrac injections are prescribed if the injuries has occurred in the open grounds, and the patient should be followed up for after 1 week. But make sure that you start or initiate the endodontic therapy within 7 to 10 days. There are certain points which we have to keep in mind, that if because of any reason, if at the site of injury a wrong tooth has been placed in a wrong socket and you also could not see, so you have 48 hours time just to place the tooth in the right position and the right socket. Splints are always advised to be used at the middle third of the teeth because as far as gingival health is concerned, these splints they are not very gingival friendly. So we have to keep in mind that these splints are away from the gingiva, and in cases of alveolar fractures, these splints are given for at least 4 to 6 weeks. In second situation where the patient could not or the attendant could not reposition the tooth back into its socket, but they have taken the tooth in any media or in a hanky, and the patient has brought to your clinic within 60 minutes, then we have to just see whether the dirt and any impurity which is attached with the root surface should be removed by simple irrigating the root surface through with saline, and then the tooth should be positioned into the socket, and then it is splinted for 2 weeks. Rest everything remains the same, and make sure that you start endodontic therapy within 2 weeks. Means the splint has not been removed, but you just initiate the endodontic therapy. The third situation where the injury has occurred more than 1 hour back and tooth could not be replanted or replaced into its own socket, and the attendants have brought the tooth after 1 hour of the injury. So in such cases also we have to just ensure that root surfaces are all clean. So with the gentle irrigation and agitation with normal saline, we just have to clean the root surface and then try to replace the tooth and splint it with the help of flexible passive splint using 016 wire. And at least for 2 weeks, this splint should be given, and the patient should be advised, or patient should be instructed that because the time has elapsed more than 1 hour, so chances of survival of this tooth are really poor, and accordingly the patient should be made up the mind. So if it is an immature tooth, everything remains the same. The only thing that the root canal therapy or endodontic intervention should not be initiated until there are clear signs of pulp necrosis or resorption, which can be seen in the radiograph. Otherwise, these immature teeth should be left after 2 weeks of splinting. There are a few important considerations. One, the question arises whether LA should be used with vasoconstrictor or without vasoconstrictor. So there are very weak evidences to support whether the LA should be used without vasoconstrictor. So as of now, you can use LA with the vasoconstrictor or without vasoconstrictor. But important thing is that instead of using the infiltration anesthesia, the block anesthesia is always recommended if you have to replant the tooth and splint it. As far as systemic antibiotics are concerned, the amoxicillin remains the drug of choice. The second can be given the tetracycline or doxycycline if the patient is more than 12 years of age. Now, in the earlier guidelines, if you see, there was a surface preparation using the topical antibiotics of like doxycycline and putting the tooth into some sodium fluoride solution. But in the recent guidelines, they have concluded that because of the weak evidence to see any benefit of topical antibiotics or surface preparation of the avulsed tooth, it is not recommended, and please do not waste time in surface preparation. Rather, it should be immediately replaced in the socket and splinted. Tetanus immunization, usually pediatrician should be consulted whether the tetanus immunization is required or not. But as a general rule, or countries like India, if the injuries has occurred on the open ground, we recommend to give a dose of tetanus toxide. Endodontic considerations, we have already discussed that it must be initiated within 2 weeks after the injury. Even the splints have not been removed, but endodontic intervention should be started and should be done under strict isolation. The calcium hydroxide is the first drug of choice or the intracanal medicament to be used in situation of 1 and 2, where the tooth has been replanted within 1 hour of injury. But if the injury has taken or the management has taken more than 60 minutes, then it is advisable to put first corticosteroid and antibiotic mixture for at least 3 weeks, and then calcium hydroxide dressing is to be given, and patient should be informed. The expected outcome is the ankylosis, and tooth may go into infraocclusion. Doctor, I will just take another 1 minute. Okay, I'll finish quickly, right? So for open apex, as I told you, that we are not supposed to initiate any endodontic therapy until there are clear signs of resorption or necrosis. But yes, if the chances of necrosis or the clear signs of necrosis are there, then we have to initiate the endodontic intervention, and we can choose amongst the apexification or pulp revascularization depending upon the situation. Now the last question which arises, whether the replanted tooth, the primary tooth should be replanted. So there are very, very weak evidences which are available as of now to replant a primary tooth which has been avulsed. So as of now, the IAPD guideline 2020 says that our primary teeth which are avulsed should not be replanted. So at the end, just to conclude, these traumatic dental injuries occur most commonly in children and adolescents, and if the management is not given in time, there has to be a permanent loss of the tooth which has long-term lifetime consequences. So, and that is why it is important to have a thorough knowledge about these kind of injuries and their management. And following the trauma guidelines which have been released by IADT in 2020, the studies have shown that following the guidelines will give you a better results. So once again, thank you so very much, IAPD virtual platform, for giving me the opportunity to share my views, and Dr. Halabi for nicely introducing me. Thank you very much. Over to Dr. Halabi.
Well, thank you very, very much, Dr. Nikhil. This is an amazing, amazing presentation. Actually, we could sit there and listen to you for two more hours. Unfortunately, the time is limited. Yes. So is it okay? Do you have time to take just a couple of questions?
Yeah, please
Doctor?
Go ahead.
Yes.
Yeah, please go ahead.
Well, what I'm going to do actually, and thank you very much for the audience, amazing audience. They have, you know, liked sort of placed some likes on some questions. So I'm just going to choose some of the questions that have more likes. And then please, again, I urge the audience, the participants, please to go to the WOVA software, the app, and I'm sure Dr. Nikhil will be happy to answer the questions. The question, actually, there's a question that was kept repeating, Dr. Nikhil, and it goes, how to manage a blood clot in the tooth socket following luxation injuries?
Yeah. Actually, that is not the clot, but it is a half-formed clot. We call it as a coagulum. So it is always advisable, if the tooth has not come out from the socket, then by gentle pressure, by back and forth movement of the tooth, we just try to fix the tooth in the socket and we splint it. However, if the tooth has completely come out of the socket, then we have to irrigate the socket, remove the coagulum, and then replace the tooth.
Perfect. Thank you very much, Nikhil.
Thank you.
Okay, the second question is about the flexible splint.
Yeah.
You use orthodontic wire. Can I know the material, if it's stainless steel or something else? And is it round or rectangular? And what size, please?
Yeah, what we have been using is a round wire, which is usually oven 4 wire. Oven 4 wire, which is used in the socket, because we have to see if we are using the rectangular wire, the chances that we will not be able to provide the physiological movement of the tooth during splinting. So the round wire will facilitate the physiological movement and it will allow some function during the splinting.
Perfect. Thank you, Dr. Nikhil. Another question about the best time to assess the outcomes. What is the best time, doctor?
Actually, depending upon the severity of the injuries, the times are different as mentioned in IADT guidelines. But yes, certainly, if you see where the dentoalveolar fractures have happened, the follow-up time starts from 2 weeks onward, 2 weeks, 4 weeks, and then 1, 3, 6, and 12 months, and thereafter on yearly basis. But however, in the concussion injuries or in subluxation injuries, the follow-up can be done after 1 month and thereafter 1 year. So that depends upon the severity of injury.
Thank you. And another question about the gray-brown discoloration in primary teeth with negative response, but no signs of infection. Should we wait and watch, although risk of resorption is there, or should we start endodontics at once to prevent possibility of resorption?
In primary teeth, actually, if there is a discoloration, if the patient is free of sign and symptoms, usually we just leave it as such. Otherwise, if the patient has a sign and symptoms like to the standard, or there is a formation of sinus on the tooth, then endodontic intervention is required to be done.
Thank you. Thank you very much. And there's another question about calcium hydroxide. How long would you recommend to place calcium hydroxide in the root canal before obturation, in view of the opinion that prolonged placement of calcium hydroxide increases the risk of cervical root fracture? What is your opinion, Dr. Nikhil?
Minimum for a one month intracanal medication with calcium hydroxide, but maximum is 3 months. What the guidelines and the studies have suggested, they should not be placed, or it should not be left in the canal for more than 3 months. So between 1 to 3 months, depending upon the severity of the injury, and by seeing the clinical sign and symptoms, we can just remove the calcium hydroxide.
Thank you, doctor. Another question about extruded primary tooth. Can an extruded primary tooth be repositioned and splinted if not more than 3 millimeter, but interfering with occlusion?
Yeah, that's a very good question, actually. See, the primary tooth which has extruded more than 3 millimeter is extremely mobile. So the splintings are not recommended as far as this kind of situation is there. So if these teeth are extremely mobile, it is better to extract rather than splinting the tooth, because we all know that splinting a primary tooth, one, the child cooperation is very, very less. The children who have sustained injury will not cooperate. And even if you go for GA to give the splint, there are high chances that the tooth can become ankylosed. So it is always advisable if the extrusion has occurred more than 3 millimeter, it should be extracted under LA.
Okay, one more question, Dr. Nikhil.
Yeah.
Of course, we have too many questions, but I think we have time for one more. Hello, sir. When is the best time to check the vitality of tooth after a traumatic injury? When we can surely say whether the injured tooth is vital or non-vital?
See, these are the follow-up requirement. Initially, depending upon the severity, as we have just discussed now, if you just try to check the vitality immediately after injury, most of the injuries will not give you positive results. They may take 2 to 3 months time, but the vitality testing cannot be taken as a sole criteria for initiating any endodontic therapy. So you have to wait for clinical signs and symptoms of either resorption or the necrosis, and then only we have to give. But yes, as early as pulp vitality testing is to be done, that immediately after 2 weeks when you remove the splint.
Perfect. Well, I apologize for all those the wonderful questions for the lack of time to answer them, but please feel free to go to the app and post these questions. And again, I would like, on behalf of the IAPD, to thank Dr. Nikhil for this amazing presentation. I would like to thank all the participants for tuning in and for their great participation. And I would, encourage everyone to watch other lectures, be active in this very, very exciting event. Thank you very much, everyone.
Thank you so much. Once again, thank you so much. Grateful to you, Dr. Halabi.
Thank you. Thank you.
Thank you so much.